Sushil, thank you very much, and thank you for the invite to this meeting. This is a very short and abbreviated update on what's happening on the tricuspid valve. We have actually seen very good cases of one mitral valve involved and then a very challenging TAVR. And of course, Dr. Leon's talk on how the TAVR journey has reached to this point. There's so much that we take it for granted that TAVR is such an easy procedure now. On the tricuspid side, however, it's very different. And there are talks later by my friend Ani on mitral, but the tricuspid is generally referred to as a forgotten valve. And there are many cases of TR which are either sitting with heart failure colleagues or cardiology colleagues or family physicians. And we as surgeons at least see not even tip of iceberg. And by the time we see these patients, a lot of them are quite late in their TR pathophysiology. There are many challenges, and the reason these challenges are is one is the symptoms are very non-specific. Most of the time when patients see us, they are the patients who have had, say, ascites or severe limb edema. Right heart failure, as you know, is sometimes very hard to catch early. The second biggest problem is assessment of TR severity. Regurgitation is very, very volume dependent in these patients, and many times when patients see us, they are probably on optimized medication, which in real life you cannot continue beyond a point. And when we see them, they are very dry, their TR is not that bad, they are less symptomatic. However, 2 months down the line, their renal function goes down, they become worse. And by then, probably we have missed the boat. So I think this is the reason TR has always remained challenging. The surgical therapies are limited because if you look at the literature, the common number quoted for tricuspid isolated surgery is anything between 10 to 20%. So that's just the mortality at 30 days. And hence, TR is always regarded as an avoidable operation rather than something which surgeons take on. A lot of these operations are done, at least isolated TR, are in a re-op setting. So this is a patient who comes to you, you have to do a reopening, and as you know, that reoperation mortality itself varies from center to center. This is by our colleague Becky Hahn and her ECHO colleagues which published this grading. This is very important because unlike all other valves where we have mild, moderate, severe, TR tends to be probably mild, moderate, severe and 2 other grades more. What it means to us in practice is if you get something called as torrential TR to even severe TR, you may be able to manage these patients medically better. Our aim is probably with new intervention technology, necessarily at present, very few reduce it to moderate or mild. There are multiple surgical approaches which have been done in practice. Again, I trained in India, so we used to see a lot of young rheumatics. In those, we used to do something called as modified Divega or Divega. However, the current trend has been to do ring annuloplasty rather than doing any of these other procedures, such as bicuspidization. That means you just take one leaflet out, or do some form of suture annuloplasty. Based on that understanding, a lot of tricuspid therapies have been developed, and you can roughly classify them into 3 or 4 parts. The first is annuloplasty. That means something which acts at the annular level, very similar to ring annuloplasty or something similar to that. Leaflet devices, that means which either co-opt the leaflets more or aid co-optation, such as Forma device. You can have other devices. These are really novel in terms of putting valves in SVC or IVC, or of course very specific devices which are just for tricuspid. And as you will see, the tricuspid valve being the largest valve in the body, there are some challenges in that as well. The approaches for these are either through IVCs, SVC, transapical, which is very rare, or transatrial, as many devices are big in size, especially the replacement devices, and hence transatrial becomes a very easy and quick procedure. So very quickly look at the annular devices. This is to just show you the K procedure which surgeons used to do in the past, or sometimes done even today in developing world. Here, essentially, you take away the posterior leaflet by plicating the annulus on the anteroposterior and septoposterior commissure. Tri-line concept tends to replicate that. So essentially, there are 2 pleated sutures which are placed, as you can see, and then the sutures are approximated. It may be sometimes that you need 2 sets of sutures rather than 1, as this annulus, tricuspid annulus, is not very robust as the mitral or aortic annulus. This is the first in man case, which was done in Germany, and you can see that they achieved a really good result in this particular patient. I'm not going to go into the details of the trial. However, you can see the main challenge, and this is a theme across all the trials, is once we alter the tricuspid valve, it becomes very hard to pinpoint how much actual reduction you have got in terms of area, planimetry, and vena contracta. Many of these are very hard to measure as well, even with experienced echocardiographer. However, in this trial, that there was a reduction, which you can see in TR as well as EROA. The second concept is Cardioband, and I hope I can go back. This is like surgical annuloplasty. So a band is put on the tricuspid valve, and if the video doesn't play, I think here you can see it very nicely in the picture, that you place the band, something very similar to what we surgeons do in the operation theater. Again, one of the main challenges of this procedure is imaging. You have to have excellent imaging to put all these anchors. And more importantly, if you look at that picture, from say 11 o'clock to around 3 o'clock, you have got right coronary artery in proximity. And that's one of the things you can injure very easily. And this is something which the interventionists have to keep in mind when they do this procedure. This is an example from Bonn University. You can see that all the anchors have been placed. And once these anchors are cinched, which is in the direction of septolateral commissure, and you can see that there is a reduction in tricuspid annulus. And this is something, again, can reduce a torrential TR to severe or maybe even lower. Why do I say that again and again is because all these cases, which are either first in man or early feasibility, they are being done in patients who are turned down for other therapies, including surgery. So these are the patients who have really got dilated annuli and are towards the end of tricuspid rigor spectrum. Again, in their study, they have seen at present that there is a good result in majority of the patients, and further trials are underway. There are some really out-of-box concepts, and one of them is this TriCinch concept. This is something which is based on, again, a Hetzer double orifice technique. This was practiced in Berlin, and in fact, this is one of the techniques which has been published with really good results and follow-up, but not many surgeons like us do it. Essentially, this is, you are approximating the annulus from anterior to septal and converting the tricuspid into 2 orifice tricuspid valve. So can we do this similar in something similar with intervention? And this is the TriCinch concept. You put only one anchor around, say, 12 o'clock or anything between 12 and 3 and pull it towards IVC. And that causes ellipticity in the tricuspid and reduces TR. Again, early results have shown encouraging results, and the US EFS trial has already started. There are some leaflet devices, and again, many of these devices are out of box. What about Edwards Forma device? This is a spacer or a filler, and essentially this assumes that the EROA which you see on the echo, if you put a filler, you can give the leaflets a bigger coaptation area, and they will co-opt against this foam, and this is the way it will reduce TR. And interestingly, in Colombia, 6 cases have been done. More cases have been done now. With the redesign, the EFS will start any time. And you can see that if you place this properly, it works very well. And this is, however, a palliative treatment probably. One can look at it, interestingly, as a palliative kind of treatment rather than curative treatment in patients with end stage. This may work very well with patients who have got pacemaker leads, which is again the Achilles heel of tricuspid rigor treatment with intervention techniques. Again, the early feasibility studies with second generation are about to start any minute. MitraClip, as again, has been used now on the tricuspid side, and Mount Sinai is one of the centers with the Triluminate trial. People call it like fly past, means you are doing a mitral while you are coming out. You look at tricuspid and do it. However, there are some technical challenges. And one of the biggest challenge has been, one, which approach to take. Again, transfemoral approach is favored because you know how the system works when you are doing MitraClip. But bigger problem has been, as I showed you before, that the tricuspid shape and size and structure is very different. The leaflets are very delicate. The chordate structures are very different. And more importantly, there is a lot of distraction between the leaflets, so maybe hard to catch. And maybe you can catch the leaflets at one end, but the TR actually is at the other end. And that's why there are, I think, variety of algorithms which have been put forward. And in some patients, you can get really good results, while in some patients, you may not get good results at all. And the leaflets are very thin, so there is a chance that these clips, which may be heavy, especially the new clips, can actually tear the leaflet after you have implanted in few weeks. So maybe something to watch for in future. Edwards-Pascal repair system is very similar to that of MitraClip in its design and function. However, it allows you to clip two leaflets separately, independently, unlike MitraClip where you have to close on both leaflets together. So this may provide some advantage. However, again, I think the main challenge is going to be how to adopt this on the tricuspid side, because this has been designed essentially for the mitral side. And we are going to see these things. Now, completely out of box. Why bother treating tricuspid when you can actually reduce the preload by implanting devices in the IVC and SVC? And this concept was thought around 6-7 years ago. And of course, we have got some very interesting caveats of, like, the largest series at present is 3 patients, which is ironic. However, a lot of these things are done when there's nothing else available and you want your patient to be symptomatically better. So these are examples of either pre-stenting the IVC and then put a sapien valve in it. You can do that, for example, in IVCs which are around 30-35 centimeters, millimeters. If IVC is more than that, which is not uncommon, what do you do? Because the biggest valve we have got is a 29 valve. So you could either put a stent like here and then put a 29 S3 in it, which is the biggest valve we have got. But if even the IVC is bigger than that, then what do you do? And what we did in Colombia, we have done now 2 cases like this, is we did in one patient, we just opened the chest on the right side. In the other, we did a small sternotomy. And then we put a ring, mitral ring, around the SVC to reduce the size of it. And then we deployed sapien from the femoral. And this is just an example of that. This is simply to avoid a bypass, that is heart-lung machine, in these patients. And again, one of these patients is alive after 1.5 years. And we are now reconsidering him because he is out of hepatic failure for a 3rd time re-op open heart surgery. So again, lastly but not the least, what's happening in the replacement space? Because in reality, if you can implant a valve, you can take away the TR. However, in some patients, we want reduction of TR and not elimination of TR because the RV can fail. But if you have a decent RV, we can probably use this. So the only valve currently available is the Navigate device. This is an independent company based out of Cleveland. It comes in various sizes. The delivery system is at present transjugular or atrial, but we have mainly done atrial because it's a very large system. So what we do is essentially a small opening in the right chest, just like a mini mitral replacement, and pull the diaphragm down, take the purse string as you can see, and then under fluoroscopy and echo guidance, deploy the device. As you can see, this is a very short device, around 3 centimeters, 3.5 in height. What has been impressive about this device is that once you implant it properly, like most of the devices, it works very, very well. But I just want to share 2 pictures with you, is this. And when we did, this is our second patient we did, this is absolutely impressive. And this patient has been a poster child for this technology, probably being 93-year-old who goes every Wednesday dancing. So I think this is very important that all these technologies are getting there, and we have to make them less invasive, but we also have to understand how to manage TR and RV dysfunction together, not just look at TR alone. And I think this is probably my last slide, is the early experience has demonstrated that patients do present very late at present rather than early. And I think our aim should be with any treatment to reduce the TR at least to 50% than it was before. And durability of all these devices is very, very unclear. This is very early experience. Thank you.
Thanks, sorry. Thanks, Vinny. In the interest of time, I think we'll probably move on because we're running. Oh, Antonio, yes.
Regarding the implantation of the valve in the inferior vena cava or two valves, our surgeons have been very critical because they believe that this is basically almost cosmetic type of procedure. Does not really do anything for the heart.
That's what we initially thought. However, I slightly disagree because what you are doing definitely is in reducing the preload on the right heart, because your regurgitation volume is going to go down slowly. Because whatever is regurgitating, most of the time when you look at the echo in TR, you get reversal of flow in IVC. And now that volume is not going into IVC, and over the period of time, this is going to be better. But more importantly, the renal venous hypertension goes down slowly. Liver, in fact, the two patients we have done had pulsatile liver. The liver literally disappears on table once you implant these valves. So symptomatically, they become better, very easy to manage medically. And as I said, the first patient we did was actually, he had just recovering from hepatic coma. And this is a patient we decided would be ideal for something crazy like this. And this patient is now come back to us in much better shape, and we are reconsidering for a third time re-op, open surgery. So I think you can view this as a bridge to something, or you can view this as a near definite treatment.
Carcinoid patients who require tumor reductive procedure, sometimes they're a high risk for bleeding unless you do that. If they have carcinoid heart disease, and if you do a procedure like that, you can decompress the liver and then you can do abdominal procedures more safely.
Yeah, I think it's obviously not perfect, but it can help in reducing, as Vinny said, we've had a couple cases now where we did tracings and the IVC pressure, the IVC junction pressure, we had a pressure that systole went up to 50 to 60. As soon as you put the valve in, the pressure the liver is seeing was 10. So in the short term, it does improve those things. It's not a long-term solution, potentially.
Yeah.
So I think we'll move on.
Thank you.